Welcome everybody to this webinar on new standards in neuroimaging with fast AI-based quantification. My name is Kim van de Ven. I'm Senior Portfolio Manager at Philips, so I take care of the neuroimaging portfolio for MRI. And today I'm here together with my colleague, Erika Swan, from the company SyntheticMR in Sweden. And together we bring you a new product that we want to show you in this webinar. And we have a fantastic speaker today to give you all the clinical insights. So let's start a little bit high level with what Philips is doing, because what we're targeting is a fast and fully personalized exam for every patient with fully automated workflow and decision support. And this really boils down to three pillars. It's about improved patient outcomes with first right diagnosis and treatment and ultra-fast exams. It's optimized workflows, and it's maximizing the lifetime value of a system, so really being more sustainable. And of course, what we're doing today with the SmartQuant technology is really about improving patient outcomes and scanning faster. So if we look at the care continuum, then we see that MR plays a dominant role in diagnostics. However, in the future, we see that MR becomes way more relevant also in the early detection phase, as well as in the MR-guided therapy. And the SmartQuant proposition that we're talking about today really fits both into the prevention/early diagnosis and the really diagnostic and follow-up phase. So it provides a lot of information that's useful for neurological conditions throughout this whole continuum. So now I'm handing over to my colleague Erika to explain you the details of SmartQuant.
Thank you so much, Kim. And I'm very excited that we're doing this joint webinar today. And I will go through the overview of the data you receive with SmartQuant Neuro. And I will only give you the high-level explanation, and then we will have Ben Kennedy to present clinical cases and how to use SmartQuant in your daily practice. So the output you see here on the slide comes from one single acquisition of a scan time around 2.5 minutes. And first you get up to 12 different contrast-weighted images, and you will receive the more common one like the T1, T2, and T2 flare, but also additional ones like phase-sensitive IR, double inversion recovery that you might not acquire today due to you want to prevent long protocols. On the quantitative side, you will get the quantitative maps, the R1, R2, and PD, as well as tissue maps of CSF, white matter, gray matter, and myelin. What is not specified on this slide that you will also get is the total volume of each tissue, as well as intracranial volume, brain parenchymal volume, as well as brain parenchymal fraction, which is a good marker for atrophy. Finally, on the bottom, we have age-stratified reference curves that you will get within SmartQuant Neuro, and that will give you an easy, quick way of seeing if the patient is within the normal range or not. So this is the information you will get from one single acquisition of about 2.5 minutes. We also want to introduce you to the clinical setup you get with SmartQuant Neuro. And SyConnect brings a zero-click workflow on-premise where you can predefine your own output that you can see in your packs for each specific protocol. So it starts with running the acquisition on the scanner, and the raw data will be automatically stored in your PACS environment, but also directly rerouted to the SyConnect server that will process the data and send back the predefined output for the specific protocol you have just run. So on this slide, we have two examples. So an MS protocol and the TBI protocol. And depending on the protocol you have run, the SyConnect server will send back the output to your PACS environment for you to review in your PACS viewing station, exactly in the same way you do with any conventional sequence today. If there's cases you want to review closer, Or if you want to look in some additional contrast that you have not has as part of your defined output, you could always open the SyMRI software from your PACS environment to get that additional information. I also want to mention that you can go back and update your already defined output for a protocol if you, after using this for some time, realize that you want to add another contrast-weighted images. So it's always possible to update the settings afterwards. So to summarize, this is a clinical setting with zero-click workflow, no manual work needed. So every output you want from SmartQuant Neuro, you will get automatically into your PACS environment. Then I will hand back over to you, Kim.
Thank you, Erica. And I indeed, I love what we see, right? On one hand, we get a lot of new clinical information, but we also provide it to you in a way that's manageable. So we're not going to overload you as a clinician with a lot of data that you don't need. So there's one more thing we want to highlight here, and that is the first SmartQuant Neuro implementation that is already available in the market is only a 2D implementation. And as you can see on the left, and as you obviously are aware, if you do a 2D acquisition, you normally do that with relatively thick slices. So reformatting on different axes is not possible. Well, this is very important in the neuro workflow. So we're very proud that together with SyntheticMR, we can now offer you a 3D version that allows that reformatting capability. So the SmartQuant Neuro 3D allows short scan times while preserving IQ. And this is because we combine the SyntheticMR approach with the Philips SmartSpeed approach. And that brings us down to 3-minute acquisitions for a full 3D exam with all that information that you show that Erica showed before. So there's a lot of value that's provided in a very short exam. So this is an exclusive partnership between Philips and SyntheticMR. So for the next year, one and a half year, this will be available on Philips systems only. So having given you a short introduction on what SmartQuant Neuro is about, I'd like to introduce our speaker of today, and that is Ben Kennedy. And Ben is the Director of Clinical and Research Imaging at Mermaid Beach Radiology in Australia. And Ben is a long-term partner of both Philips and SyntheticMR, and he's really eager to experiment with this new technology and provide the right clinical value to his referring physicians. This webinar is based on an earlier expert session that we had with Ben at ECR, and that was very, very well received. So we really want to make this available to the wider audience. So without further ado, I'd like to hand over to Ben Kennedy. And Ben, thank you very much for joining us online. And we're so much looking forward to hear your version and your insights on both SmartSpeed and and SmartQuant. Thank you very much for joining us. Also, thank you to the audience, and I wish you a very nice webinar. Thank you.
Thank you, Kim and Erica, for that nice introduction, and thanks to Philips and Synthetic again for all the work that we've been doing together. It's a pleasure to talk about the work we've been doing, and it's exciting to see where this is all going. So looking at what we've been doing with SmartSpeed, we're at Mermaid Beach Radiology on the Gold Coast here. We're a private clinic and research facility. We currently have a 3-tier Philips Alicia X. We have a long-term clinical sciences collaboration with Philips Healthcare, currently working on first-of-kind SmartSpeed in the current and future iterations in the combination with our existing development. We have multiple university collaborations as well. So speed versus quality over the years is very subjective to the needs of a clinical practice and for financial sustainability. There's a lot of challenges: speed versus clinical accuracy, profits versus healthcare quality, increasing cost of healthcare versus access. Can we have our cake and eat it as well? Well, AI is definitely taking us closer. So SmartSpeed innovations have been having a global influence on our protocols. There's no compromise in applications. All Cartesian and non-Cartesian 2D and 3D options. Our clinical practice has principles where SmartSpeed really accommodates. Best in quality, best in diagnostic confidence, speed, quality balance to a new level. There's always going to be a balance between there, but the level of the bar is much higher. Much more consistent booking times, ability to apply new innovations in clinically feasible times is very important. Being able to run things routinely instead of every now and then, it takes the decision making out of the process. All parties win here, the patient, the referrer, the radiologist and the technologist. So Adaptive CSNet is used very early in the recon pipeline, and this is really important with Philips in the way that they use Sense. It uses specifically trained undersampling pattern. And at this point, it has access to all the raw information before combining the individual channels. So by having this raw information, you actually have the bare bones of everything coming through, the multi-channel input of incoming case space and core sensitivity info, as well as the background information. So it integrates the original individual coil element raw data iteratively for the trust of the output data for maximum consistency and quality. And with this, we get maximum accuracy for true data. And this is perfect for quantitative MRI, and this is where we're all headed to. This is really just a basic diagram, but essentially just showing that majority of SmartSpeed is done right at the beginning. So we're making sure we're not throwing out the baby with the bathwater. We're getting the maximum accuracy and maximum quality. So the future of MRI, it's not just seeing more, and it's not just speed, but it's actually measuring it, except faster. It's an exciting time in MRI right now. In the clinical world, quantitative imaging for a long time has been very unreachable, intimidating, confronting, ignored. There's lots of adjectives you can use here with the clinical side, but it's something that where the software is written by PhDs for PhDs, and clinical correlation to results is a very steep learning path. So no wonder radiologists and referring clinicians are reluctant to learn what is possible these days and investigate new ideas. Okay, so the first methods of quantitative MRI have been around for a very long time. We've known DWI and DWIBS and DTI for a very long time, and it's something we really haven't thought of as quantitative, but it's really where it all began. It's now compatible with SmartSpeed, now supporting EPI readouts, so it's really improving the quality of this quantitative MR. Now we have tissue quantification used with SmartSpeed becoming mainstream. We see that with cardiac and liver at the moment, but there's other ones coming through. But this is translating research into clinical applications in clinically relevant times. And clinically relevant times are very important because it's just not feasible to do all this stuff unless you can do it in a time that fits in with the clinic demands of patient throughput. So you're improving your speed, your accuracy, and your confidence, everything that you need. So SyntheticMR has been around a little while now. The initial clinical utility of this was multiple contrast data sets from one sequence. So now it's also specifically mapping the tissue properties. So if you look at T1, R1, T2, R2, myelin, CSF, grey matter, white matter, volumetrics, for the brain, this is quite a big leap forward. You can use it for comparisons with large population of data or comparisons with multiple studies over progression for multiple time points. The data is now presented in a clinically acceptable format, which is creating more confidence in using it for clinical decisions. This is where radiologists and physicians are now getting more confident looking at these images and actually coming up with even new ideas. So validation has been done over many peer-reviewed studies in collaboration with traditional quantitative relaxivity over the last many years with synthetic, looking at traumatic brain injury, MS, myelination versus axonal damage, occurrence of remyelination, Alzheimer's, stroke management, all the big ticket items, especially tumour classification, staging. These are things that are really hot topics in the world of MRI, and the more that this comes through, the more that we can understand and trust this data. So this is a lot of the work's already been done and helping us progress forward in the translation. So the synthetic MRI sequence routinely takes between 5 and 6 minutes or longer. The image resolution and quality is historically difficult to replace standard sequences. It also depends on the coil hardware and whether or not you have 1.5 versus 3T. Obviously, if you have a 32 channel head coil on a 3T system, you can really make a much nicer go of it. So Philips Healthcare and SyntheticMR have a collaboration with SmartSpeed capabilities. And so we're going to call this Smart Quant Neuro. It's FDA approved in brain for 2D, 510K pending for brain in 3D, and CE marked for brain with 3D. So Smart Quant Neuro, really now we're doing up to half the scan times. AI is having a profound improvement on the image quality and resolutions, which we'll have a quick look at. AI is demonstrating a much higher confidence and accuracy in validation, and you have 2D and 3D development. It's the ultimate in reproducible quantitative data and efficiency, and has become a one measurement for all quantification in a clinically standard time. And this is where it actually becomes feasible in the clinic. Here we have an example of non-AI. You can see these are quite good quality. You can see the SyMRI recon of the flare and the T2. When we go forward to the next step with the AI, you can see a marked difference in the detail and sub-detail within the brain here. I'll go backwards again and forward. This is where we're seeing a leap in quality as well as the time, where when you compare it to the standard sequences, it's something that's actually worthy of replacing the standard sequences moving forward. Here's a really good example of a lot of outputs that you can get from the single set of data, the T1, T2, the dual inversion recovery, the flare, the PD, and you've got a PSI RT1 there as well. All of this can be done with a reduction of 3.5 in about 3.5 minutes with a nice high resolution. I think you'd agree that this detail looks very, very good. When it gets to the mapping, this is a whole new world. This is where you're looking at contrast you've never seen before and showing changes that you don't see with routine imaging. And that's sort of the really big thing with quantitative imaging. Often you'll see a contrast of a tumour or a preclinical change that you wouldn't recognise routinely with the routine imaging. Then you go into the mapping, and especially with the myelin map, this has been a really important step forward. But you've also got non-aqueous, you've got white matter specifically, grey matter specifically, and CSF specifically. So all of this is very important, and it takes the subjectivity out of reporting. It makes it very objective. Then you get these beautiful graphs, a bit like taking your child down to the doctor and having a look at their head circumference and how high they are. You can map these details against large population just to see early changes in all sorts of different types of disease or pathologies. Then you get quantitative data where you're getting real numbers. And this is something that's really important, especially for physicians, if you want to see something that's having trends of up or downwards. This is our current protocol. It's very comprehensive. 3D T1, flare DIR, T2, diffusion, MRA, MRV, SWI. We do this all in about 20 minutes. By doing all of these sequences, it takes out a lot of decision making when you get different types of questions coming along clinically. And it also allows us, even though they might be clinically looking for one pathology or disease, we'll often come across something else that they weren't really expecting. So by being comprehensive, it makes it much easier to make bookings, but also not miss things that you might miss otherwise. When we exchange the T2 for the SyMRI, you can see here we've actually made a reduction in time. So there is absolutely no compromise here by using this in this format. This is a really powerful tool, especially for validating SyMRI against the routine imaging. With this, we get this plethora of outputs. And you can have as many outputs as you like with the grand scope of any parameters that you like, automated, or you can do it manually. But with the mapping between all the data coming out, it's a huge increase in data, but you can actually design how you want to see it and how you want to deliver it to your packs. So it simplifies our bookings, reduces recalls, it's comprehensive, great for TBI, pathology, epilepsy, stroke, Alzheimer's. All of these usually have their own specified protocols. However, we're really covering everything. So it's a net zero cost for SyMRI going forward. This is an example of a report that we would automatically generate. We use it in all neuro studies without workflow penalties. We said before, it has no effect on booking times, an immense increase in data achievable. The customization of this output, as I said, is you can make it all automatic to your very much specific needs. Customizing all parameters, everything really is exactly what you want. And this is really important because different clinics will have different needs and different sort of patients that are coming through. You can set it up for exactly what is going to maximize your ability to make decisions. We're currently still using SyMRI as a supplementary comparison tool for validation and development. The future prospect for us with more validation is to replace the need for contrast, or at least minimise it, and replace a lot of the traditional sequences. The goal is to continue to discover and measure preclinical changes not observed in traditional imaging, and the opportunity to create ideas and retrospectively look at data collection. This is invaluable. You can imagine after 2 or 3 years of collecting data, when you have a new idea, you can go back over all of this again and make a lot of measurements to make a lot of retrospective studies. We're now going to start with some case studies. You can see in this case here, we have a brain cancer in the medulla oblongata. We have the flare, dual inversion recovery, T1 and axial DWI. Of interest here, you can see it's quite bright on the flare, but there's no restricted diffusion in the DWI. Another thing is in the post-contrast here, we can see there's no real enhancement, both in the black blood as well as traditional T1 FATSAT plus contrast. Now, when monitoring tumours, often the rate of enhancement or the DWI restriction or ADC maps can be quite valuable for looking at progress of tumours along the way, but we have none of that here. Here's the example of a SyMRI, exquisite data coming out. You can see very good characterization of the tumour here with high detail, especially with the AI quality. But it's when you get to the mapping that we really see the substructure of the tumour. And this is where we're seeing contrast that we don't normally see inside a tumour. You can go and put little ROIs and do little measurements of any part of that tumour separately. But if you're looking at the size of a tumour or the restriction or all of the things that we normally see with tumours, the best we're really going to see going forward is it globally getting larger or smaller. By looking at the substructure of a tumour, you can actually see a lot more change in real time as you see progress of this patient. This is a very powerful tool. The next patient is a patient with lung mets, and we're looking at pre and post treatment in this case. Here we see the axial DIR with quite a dark tumour with some peripheral edema as it's fast growing. Not much restricted diffusion once again, and quite a heterogeneous uptake of contrast. When we see the structure inside the tumour here with the SyMRI data, you can see it's of a very high quality. So being able to look inside a tumour for the sub-detail is, there's no compromise in this with the SyMRI. When we go to the mapping once again, seeing the sub-detail inside the tumour is really powerful. And there's so many ways that you can use this data to look at measurements specifically, depending on what you really need to see. When we look at the post-treatment side here, the one change we see apart from the reduction in size is we're now getting signal in the DWI. And when we look at the ADC map, we can see it's still bright, so it's T2 shine through. So we can say this tumour is most likely all necrosis now and shrunken right down. And we can see that the peripheral edema is also gone. Looking at the detail again with the SyMRI data, you can see exquisite detail of the output again. No compromise here in the quality of what we're seeing compared to routine imaging. When we go to the mapping once again, you can see a marked change here in the size and what we're seeing inside the tumour here. So once again, this sub-detail, the substructure of the tumour is a really powerful tool for looking at the progression of any patient, especially pre and post treatment. We'll have a look at the pre-treatment again, and I'll go back to the post-treatment. And you can see here, there's so much information there. The next case is really interesting. It's a lipoma. You can see here is a heterogeneous T1 signal here off the FALX, and you can see dark on the DIR and the SWIP. Now, in these normal cases, you would expect this to be confused for a meningioma with associated calcification, and that's of the first thing you would look at and suspect would be that. When we go to the SyMRI data, you can see it's actually not so heterogeneous. And the bright signal in the T1 and the PSIR makes it much more like fat, to be honest. When we go to the mapping, this really confirms that if you look at the T1 map there, it's extremely rich in blue from the high fat signal in there, which when you look at the fat in the periphery of the brain, it's actually very, very similar in the darkness of that blue as well. Once again, you can map this with SyMRI for true quantification values. The next case is chronic white matter disease. Now, this is something that we commonly see in our aging population, And it's sort of subjective in the way it gets reported over time because it's sort of very diverse in the way it goes through the brain. When we look at the SyMRI data next to this, we can see exquisite detail of when compared to routine imaging. This is now being, with the AI quality, something we can trust a lot more. And then we can see the equivalent now with the FLAIR and the T2. Now, the important thing with the mapping now is we can see myelin map and white matter map. Now, by being able to map this objectively, we can actually look at true quantification of this and look at the progress over time in our aging population. And I think this is going to be a very powerful tool for something we routinely see a lot in the aging population. And I think this is going to be very strong in the research of the future. Our next case is a melanoma map. You can see here it doesn't really show up very well in the FLAIR DIR, very bright in the pre-T1 and the post-T1, and not really of any real value in the DWI. Even with the black blood there, it's sort of quite a heterogeneous signal, but between pre and post, there's no real obvious sign of enhancement. And this can be tricky without a very good subtraction as well. When we go to the mapping here, this is where we can see quite a powerful tool. The darkness of the blue on the T1 map and the red in that R1 map, and for the PD map, you can see it's quite strong as well. Quantification-wise, you can see this is extremely strong. And where contrast wouldn't really be of any use here, this is a great example of where quantification may be used to be able to depict what type of tumour as well as grading it as we go into the future. As a lot of studies have been showing. But by being able to have these values here, it's something we could trust rather than the use of contrast in future studies. This is a great example of something I think we can actually see what it is, but it's something where I think quantitative MR could be something that we could really use as an exception here to traditional imaging moving forward. The next case is osmotic demyelination syndrome. This is quite an elderly patient. It's a type of demyelination that's not commonly seen. We're used to seeing MS patients, but essentially it's most common in the pontine white matter tracts after a rapid correction in metabolic disturbances. For example, hyponatremia, where you have cerebral apoptosis with loss of myelin due to osmotic stress. Patients don't tend to do very well with these. But when you're looking at something that can be subjective looking, being able to measure this with mapping and look at treatment therapies to see if there is any sort of recovery on these, this type of quantitative imaging is extremely powerful in seeing if they are getting any improvement. This is an area that they don't often get improvement, as I said. So being able to look at therapies and actually a therapy that would work, this would be very powerful in developing new therapies. Our next case is a low-grade glioma. You can see here traditional imaging, the DIR, T1, the diffusion, and the T1 fat cell post-contrast. So you can see once again here, another example of where DWI isn't showing any restricted diffusion and no contrast enhancement post-contrast. We can see here another example of exquisite detail, no compromise in the quality of the SyMRI detail coming out in their outputs. And with the mapping here, once again, you can see the sub-detail of the tumour in a beautiful way. And looking at that sub-detail, this is where, instead of looking at purely the size and contrast enhancement, as we said before, looking at sub-detail of the tumour, the structure internally, there's so much more you can monitor with this moving forward to show any early changes. Now, traumatic brain injury or concussion, this is something that's quite a hot topic in many places around the world, whether it be for car accident victims, high velocity impacts, or sporting injuries. This isn't one of our cases, but I wanted to include it because it's something that I have a high passion for, and I think that it has a huge future. When you come across patients with traumatic brain injury, the ability for them to stay in a scanner is actually quite difficult. And they fatigue very easily, and looking at traditional ways of quantitative MRI, they can be quite lengthy. To be able to do a 2 or 3 minute scan on someone who's had a traumatic brain injury and actually have quantitative data spit out immediately, I think if you can use this to grade and basically be able to make assessments of changes that you can't see with routine imaging, this is really going to impact the treatment of patients early on, which is very important. You can see here on the T2, there's no real change at all. And a lot of people come in with brain injuries that the brain looks totally normal. So being able to show an obvious change in quantitative MR like myelin is extremely powerful tool, because early treatment for these people is absolutely crucial for great results. So we're going to have a look now at, you can see here some ROIs on axial R1 maps. You can see a little plot down there below, and you actually get quantification up in the top corner here for absolute R1 and R2 values, PD values. This is a powerful tool that, like we said before, you can interrogate structures inside a tumour or different parts of the brain. The thing about a brain is that when you're doing 2D cuts, you go to look at the other planes here, there is a little bit of a risk of partial voluming into other structures. So by going into 3D, you can see here that you can do ROIs in multiple directions, and without the 1 by 1 by 1 isotropic resolution, where you can be a lot more even accurate again for different types of pathologies that would really benefit from this. So with a reduction of 8, being able to do 3D isotropic down to 3.5 minutes is very, very powerful. You can see here ROIs in multiple planes. You can see in the coronal planes there giving plots. And then you can see you're going into R2 mapping, T1 mapping, T2 mapping. You can see that that is going to be of a high value in the brain specifically. We're now going to have another look at our current brain protocol. And if we was to substitute our routine imaging for the 3D, you can see here at 3.5 minutes, this total scan time comes down to 12 minutes. And when we have a look at the amount of data that we actually gain from this for that amount of time, this is now making huge leaps forward in what we're achieving with such a short scan time. All of these are 3D, which means they can be multiplanar reconstructed. It's endless the amount of data you're getting, not only for the outputs of each sequence parameter, but also for the mapping and volumetrics that you're seeing. One of the things to be careful of here is the amount of data coming out here will really fill up your packs. So really tailoring what you want to put out of this is something that's totally up to you, but you always have the choice to go back and manually interrogate anything after the fact and customize what you want. But it's an amazing amount of data that's coming out of these, so it's quite an exciting time of scan time for the amount of data that's coming out. And next case we're going to look at is a comparison of 2D to 3D with MS. Now with MS, it looks beautiful in 2D, but when you're looking at something that's global and it's sort of coming off different structures, you can see how 3D, especially in some of the other planes, is really powerful. You can see here some traditional imaging with axial flare, DIR, T1 and diffusion. When we go to our SyMRI outputs, you can see very good detail, high quality of each of these outputs, and the sub-detail inside these plaques is very excellent as well. When we go to the mapping, once again, it's a whole new world of what we're seeing inside the plaques and being able to actually quantify what's inside. And then after the fact, going in and looking at sub-detail inside. Once again, the myelin map is a very powerful tool and the quantification of all the myelin going forward. When we do the reconstruction of this, obviously the sagittal for these looking at Dawson's fingers coming up is quite an important part of looking at MS. And looking at the mapping here, you can see it's also a challenge. So let's have a look at the 3D version. The 3D version here, 1 by 1 by 1 isotropic. We can see it looks beautiful in all the outputs. And then we do the reconstructions here in the coronal plane and into the mapping. We're now seeing exactly what we would normally see, but exquisite detail of the multiplanar reconstruction without any partial voluming. Being able to do this at 1 mil isotropic in the time we're doing is really going to absolutely transform how we do brain imaging going forward. Now let's have a look at something a little bit more complex, like a glioma, quite a high-grade one here. You can see these outputs here, extremely high quality. And I would put this against any traditional imaging for actually the quality of what we're able to see inside the structure of the tumour and everything around it. Absolutely exquisite quality with the new AI. Once again, though, with something like this, it's quite complicated. When you want to do multiplanar reconstruction, if you're trying to do it in 2D, you're really not going to get what you need. Let's have a look at this in 3D now. So with, once again, 3.5 minutes, being able to put out as many outputs as you like, being able to have totally customized parameters as much as you like, the amount of detail you can get of tumours now is exceeding anything we've ever seen before for the time. Let's have a look at the coronal plane and the sagittal plane here. I think you'd all agree that the quality of what we're seeing in the substructure of that tumour is excellent. And I think this AI is only going to keep improving as we go forward with 3D. Looking at the mapping now, this is beautiful, being able to look inside the edema, look inside the substructures of the tumours. This is where going and interrogating different parts of the tumour and different parts of the surrounding edema is really powerful to be able to assess the progress of tumours as you're going forward. And for someone like this, I'd imagine that these types of decisions are not made easily. Once again, here's the coronal. And you can see here some examples of interrogating different parts of the tumour, whether it be in the actual tumour centre itself or out in the peripheral edema. Being able to have these plots and true quantifications is very, very useful for looking at the progress of anything. The interesting thing we're coming across is when you're looking at the mapping, which type of tissue is actually the most dominant in going forward. So sometimes inside of edema, you want to see, is there any myelin left inside there, or, you know, different types of structures that may be inside the edema. So this is something where you can actually put a ROI on top of it and actually assess quantitatively what's inside. So we normally get this data with absolute numbers coming through of CSF, grey matter, white matter, myelin, and for global values. Now, if you put on a little ROI there, you can see U, M, or user mass. You can actually have a look inside there and actually look at true numbers where there is any myelin inside. But it's a good way of really interrogating specific areas going forward. I think this is really just scratching the surface of where this software is going to go. But being able to be presented this type of data in a way that you can actually think outside the square and sort of interrogate things however you want gives you lots of flexibility in how you can use this type of software. So where are we going with this now? Eventually, it's really heading towards a one-stop shop with a 3D smart quant. Eventually, I'd like to have either no or a very, very reduced amount of contrast injections. And with the transition into 3D, most currently with the Neuro 3D, there may be a possibility working forward of adding MRA and possibly DWI capabilities, but I think that's still a work in progress. But imagine just doing everything in 3.5 minutes. I think it's almost too good to be true, but from what I'm seeing so far, we're very, very close. We're also transitioning to outside the brain, and we've been doing some wonderful work in breast, prostate, spine, MSK. There's lots of other areas here. We are really scratching the surface. There's new validations of quantitation that we're seeing that we're not seeing inside normal imaging. As I said earlier, often you'll have someone present with known, we know they're concussed, or they know they're injured, or some other clinical indication, and the imaging looks normal. Being able to validate this with pure quantification is where the future is headed. We're definitely at the tip of where this is going to go. We now have an evolution format that's clinically acceptable and becoming more user-friendly to the mainstream clinicians to use as a tool, and especially for making future interpretations and decisions. It really comes down to how is this going to change the life of our patients? And once again, the accumulation of data is going to be a king here. When you have this much data per patient and being able to build up this sort of data over a number of years, having new ideas and retrospectively going over the amount of data, it's going to be endless what you can do with it all. Take-home messages. This is really becoming a one solution to quantitative mapping. It allows significant flexibility on what you want to measure. You can have automated outputs for tissue quantification, various tissue-specific volumes, and comparisons with populations of data. The data is presented in a clinically relevant format, something you can actually use to make decisions. And this really benefits radiologists and referring physicians. You're getting reproducible data maps and tables, which can help make clinical decisions, especially looking at trends, and validate clinically relevant presentations. So we're looking at something that's quantitative, you're taking the subjectivity out of most of what you're looking at. And then from there, create your own tools of measurement and go to what your clinical relevant needs are. In all of this, one of the most integral parts is SmartSpeed. Being able to both speed it up and improve the resolution has been integral to achieving real-world clinically achievable times to get something that's actually going to help you make new decisions and benefit everybody. So thank you very much for having me. It's been a pleasure to show what we've been doing, and I'm very excited about the future of where this is going. I really hope in the future we can be showing you a lot more exciting evolution of where this is going. Thank you.
Thank you very, very much, Ben. That was a great presentation. As you mentioned yourself a couple of times, we're still scratching the surface with this quantitative technology. There's a lot still to be learned. You show the versatility, you show the possibility to use this across different diseases. And I have a couple of questions for you. So the first question is, if you have to place your bet on a certain clinical application where this quantitative imaging is really going to make an impact for the clinician, but also for the patient, is there any disease area where you think the biggest impact can be made, maybe on the short term?
Thanks, Kim. Yes, that's a very good question. I think that the most obvious thing to me would be early detection of disease, things like possibly early Alzheimer's or diseases that are clinically often not picked up until later in their progress. Being able to see quantification of maybe increased amount of CSF due to atrophy of the brain in an earlier age than expected. Picking up early signs of tumours or just earlier, I guess tumours is the most obvious for what people will normally think that they're looking for. But one of the things that really came to mind for me was looking at early Alzheimer's in people in their, or even Parkinson's, in the people in their sort of mid-30s to mid-40s looking forward. I don't think we're quite there yet, but it's something that just looking at basic, just volumetrics of the brain and CSF, if you were to see an area that's not sort of within keeping of someone of that age, it certainly would warrant having a further investigation as to what else is going on there. I think neurologists in general, most of what they do is clinical in the way that they assess patients, and a lot of imaging is done to exclude a lot of pathologies otherwise as another cause for what those clinical indications are. So being able to show quantification for these, I think the myelin map is a huge possibility for not just demyelination or MS, but just showing global changes for, whether it be changes in brain function or, traumatic brain injury as well. There's going to be lots of things that you're not seeing in routine imaging, but you're seeing in the quantitative imaging. I think that's really going to be the theme going forward in this, is that what can't we see that we can see with quantitative imaging? And it's going to be something where it's going to be the earlier we detect these sort of changes, the earlier we can start treatment. And this is where we're going to extend people's lives. And this is where we're going to make, families, happier over a longer period of time. If you were to pick up an early Alzheimer's and start a new drug therapy or start a new treatment of some kind early on, you're going to get a much improved outcome here, rather than wait until it gets past a certain point and they're sort of gone off the cliff edge in where they are clinically. So it's a great question, because it's actually quite hard to answer, but it's really seeing what we can't see without traditional imaging, I think.
I can only agree to that, Ben, and I think the fact that we're scratching the surface with this also makes it quite hard to answer that question, because there's multiple areas where I also see that the impact of quantitative imaging can be huge, and there's still a lot to be investigated there. Another thing that you mentioned is reduction of contrast agent, and I think that's also a very pragmatic approach of further adoption in combination with the time gain that you have if you go to 3D Smart Quant. If you could reduce the contrast agent usage, then I think that has an immediate impact on a clinical practice. Is there any specific area where you see that it's probably going to fly the easiest, this contrast agent reduction?
That's another really good question, Kim. I think the most obvious area I could probably say is a lot of, well, tumour follow-up is going to be the most obvious, because if we've already characterised the tumour, being able to show the subdetail changes, not just size and everything else going forward, I think has a huge potential to negate the need or reduce the need for contrast in follow-up. But even in the initial classifications of tumours, I'd like to see at some stage in the future where they're so confident with the type of quantification that they are getting that they could characterise tumours with a lot more confidence. I know there's been studies where they've actually done this successfully, but I think that this is an area that with a lot more work will definitely become reality. And like I said before, it's going to be an accumulation of data over a long period of time to learn a lot from what we're seeing here. And now that we've got an interface that clinicians can interact with and use their ideas, I think we're going to see a lot more progress in that space. For other types of reasons that we would give contrast, I don't think there's much apart from really tumour classification that I can think of, apart from, say, perfusion studies for purely brain functionality. But even with that, I still think the quantification side of the brain is really going to take over after a long period of time. It's just a matter of, we're learning how much this can show, and I think in the next 5-10 years, we're going to see people that are very, very smart with great ideas come out with, lots and lots of data and to validate what they're seeing. And eventually we're going to have predictive medicine. We're using AI models looking at this data, who are going to be much better at looking at this data than what we even are. So I can definitely see that where we're going in the future.
Yes, Ben. I think I can only agree that the brain tumor space is probably the space where a lot of contrast agent reduction can be achieved. While we are not there yet, I think you showed one case, and I think that was case 2 with the lung metastasis, where you actually use SyntheticMR post-contrast. And I'm not entirely sure if I was correct there, but can you allude to the usage of SyntheticMR, the smart quant technology, in a post-contrast case? Do you use it that way?
Yes, Kim. This is something that we wouldn't routinely do, but it's certainly something we're experimenting with. I guess with everything, when you've got a tool like this and it only takes a few extra minutes and you're using it for comparative data, being able to give contrast and actually do it again after contrast, it's really important to see what are we seeing or what are we missing. By being able to fully look at pre and post contrast, it's a much better way of assessing, is contrast really that important and is it adding anything? When you're looking at T1 maps or R1 maps specifically, this is where the post-contrast data may be of some value. But then again, I think it's going to take a lot more validation to prove that. But until we actually have data pre and post contrast, it's going to be hard to prove what we're trying to achieve. So when we have the ability to do that, especially if we have really interesting pathology like that, we really want to exhaust every possibility of what we can learn from this type of quantitative data. So yeah, it's not something that we would see as a routine going forward, when we have a lot more experience with it, but it really depends on what we find going forward. And at this stage, I guess we're sort of also looking at, does it increase sensitivity? Does it increase any value in the scan whatsoever? And I think the jury is still going to be out for a little while on that, because we're still learning a lot from it. But I think it's invaluable data to gain and collect over time to try and learn for future decision making.
And then one final question that ties a little bit into what you're saying. We're collecting, and you are collecting, a lot of data right now. And that data is required to do the research to even better understand the value of quantitative imaging. Practically, how do you deal today with that data? Do you already make specific outputs from SyntheticMR pipeline to diseases? Or do you just store everything at the moment? I'm very curious how you deal with that and how your PAC system is dealing with that.
Yeah, that's it's very, very important to understand that. We're doing two things really. We're being quite controlled in the outputs that we put out to what we need for now. I think that as we transition into replacing all traditional sequences with the outputs, we'll probably find that we'll have more outputs coming out. But while we're doing direct comparisons, we probably have a more controlled amount that automatically goes to PACS. Still a fair bit of data, don't get me wrong, there's still a lot of data, but being to control that, you can sort of control how much it impacts your PACS. One of the important things though is we send our raw data to the PACS. So we always have the ability to go back to our raw data after the fact. So the raw data doesn't actually take as much data as you would have for the outputs. If you had 20 sets of data coming out from the outputs, that's going to really add up. But the actual raw data itself is easy to save without too much impact on the PACS. So that's also been a big part of what we do going forward. So if we ever want to look at any specific type of case again, going backwards, we can actually reevaluate the raw data in the user interface to do manual ROIs or different types of parameters or different maps again. And I'm sure the evolution of the type of mapping that's going to come out in the future is going to improve. There's going to be different types of maps that we're currently not even seeing. So we can even go back to the raw data again and then have another look at that data with the new mapping. So as long as we're saving the raw data on the PACS, I think that's really important for us being able to reevaluate things in the future.
Yeah, that sounds like a pragmatic approach. And I think what you mentioned is indeed very interesting. We didn't squeeze everything out of the technology yet. So having the raw data available on your PACS and being able to go back and study new quantitative contrast on existing data, it's going to be very, very valuable in the future. I think I want to close our webinar right now. I want to thank you again. I want to thank the audience for watching this. 3D Smart Quant is coming at you this year. So we're really keen to connect also with you and the audience. If you have questions, please reach out to us because we can provide you with more information. And then once more, Ben, thank you very, very much for this really nice overview, very comprehensive, many different cases showing the power of quantitative imaging in the future, but also already today in your practice. So thank you.
Well, thank you very much for having me, Kim and Erica, and I thoroughly enjoyed it, and I look forward to where we can show you a lot more in the future.